Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
Okay, it's 9 o'clock, so I guess we could begin. Uh, Two interesting articles in the Washington Post this Monday. First was a 101-year-old man who shared 7 reasons why he thought he lived to be 101. Uh, Very interesting because he details the many things that he's had over the course of his life with heart attacks, accidents, and but he identifies 7 factors that may contribute to his longevity. First thing is he's been married to the same wife for 79 years. So he believes that the relationship is a very great part of why he survived. His wife is 97, and she's had many illnesses as well, and fractured hips and those kinds of things. He talks about the fact that he had a heart attack at the age of 39 and had carotid surgery uh, and a stroke at 89. So it wasn't that he was free from diseases. So he wanted to let everybody know that it had nothing to do with the fact that he had a life free of complications, because he'd had many complications. But he felt that having a friend for life who was at his side contributed greatly. Second thing he thought contributed was the fact that he didn't smoke. The third factor he gave was that he exercised daily and ate healthy, avoiding uh, red meat for the most part, although he uh, he did indicate that he ate a lot of fruits and vegetables. And his exercise daily was something that was an important part of his life. And the fourth item he said was that he had a very positive attitude and was not uh, depressed by the negative things that happened, and he always had a very positive attitude. And then he visited his doctors appropriately to get the best kind of health care he could. He's had the same cardiologist for 20 years, of course. He's outlived his doctors and his friends. Uh, and then, of course, he felt that the fact that he's had a job in which he worked meaningfully and as a journalist, he thought that that was a very contributory factor. And then he felt that his of all those things, that 79-year relationship with his wife and the positive aspects of all of that were extremely important to his longevity. Any comments or thoughts about what this 101-year-old white male uh, shared with us?
Good morning, everyone. Um, it's amazing that you would have picked that as your first topic. One of the members of the Liberty Baptist, where I grew, um, just recently died, and he would have been 100 um, this coming February. But one of the stories that he and his wife, who died either earlier this year or last year, um, one of the stories that they told often was that he met her when he was seven, when he was 18, she was 17. And they got married after he went into the service in World War II, but they were the only two factors in their life from the time they met until they were parted by her death. And they had been married when she passed for 80 years.
Hmm.
And they were a solid couple.
Wow, that's
Yeah.
pretty solid.
Yes, they really were.
Uh, wow, wow. Thanks for sharing. Any other comments? Okay. Well, I thought it was very interesting. Uh, I thought of uh, Tatum's father, who was 101 when he passed as well. So, and then the second article that I thought was extremely interesting. We've had a lot of talking about the hot flashes and the menopause, and uh, they now have a new drug that is not a hormonal drug that is now effective for the hot flashes and the other side effects of menopause. And they emphasize that this is not toxic to the liver. And uh, so far, remember, it's a new drug, so they haven't really used it long enough to give an analysis of what's going to happen to it after 5 or 10 years. But the fact that it's not hormonal, that you, whether you have breast cancer or not, you could take it, was something that is brand new because most of the other drugs that used for hot flashes are hormonal. Of course, gabapentin, we talked about last week, is used for hot flashes as well. But this new drug is something that is very desirable because it is not hormonal and is not affected by whether you've had cancer or not. They also talked, interestingly enough, they talked about its cost, indicating that it would cost about $625 for a 30-day supply, depending upon whether your insurance covered or not. But if insurance covered, it would only cost $25 a month. So it's economic, and they close by saying that it's really important that we don't take that we take hot flashes seriously because it's very disabling and uncomfortable for many women. So that this is something that may be very good for women who otherwise wouldn't have a medication to take for postmenopausal syndromes. Any comments or questions about this new FDA-approved drug? Okay. If there are no other comments, I guess we can start going through the articles.
I wanted to say something about that drug. Uh, you know, some women have hot flashes worse than others. Some have it, some is very serious and very annoying. Um, and then there are others who don't suffer from it as much. So I think that drug would be appropriate for those who have hot flashes that are real hard to deal with.
Thank you for sharing. Any other comments?
Yes, I mentioned when we spoke about hot flashes a few weeks ago, I have a family member, well, she's like a family, who is having a serious case of hot flashes. Carol and I were saying how we all go through it, but at different levels. Of course, I went through it too, but nothing that I can say was something that I couldn't deal with. And it does happen again from time to time. But that young lady had a serious problem with it and went to many doctors. And there was some stipulation about hormones because her mother was a cancer patient, a 3-time cancer patient. Certain treatments they didn't want to use for her. I told her about that article. So I'm hoping that she'll follow up on it.
Good, good, good.
Mm-hmm.
Okay. Right. Oh, this is an article that my daughter and I put together for our church, and I think it has to do with what actually uh, Darryl has talked about a lot, and that is that inflammation is part of the aging process, and the more anti-inflammatory diet you have, the better off you are. And this uh, talks about the things that fruits and vegetables that have the anti-inflammatory components. And of course, that's an important part of it. As you see here, we talked about the fruits and vegetables and cauliflower, broccoli, and the fruits that are antioxidants. And uh, these are very positive in terms of increasing your ability to have a good immune system and fight off the inflammatory components. And then, of course, exercise and plenty of sleep, and then learning how to deal with stress. And I think this is one of the aspects of it that we tend not to talk about, the importance of meditation and along with the exercise and yoga, all are ways in which we can minimize the negative impact of stress. And then, of course, uh, they talk about the uh, gut microbiome, and here again, the probiotics that people take are important. And they also talk about taking some of the other medications like ibuprofen. Abuse or overuse of these can harm the GI tract as well as the kidney. And then we also mentioned up there about sleep, the 7 to 9 hours that are recommended, sleep being very important. And then trying to keep your body weight around a BMI of 30 or thereabouts, and keeping in mind that, yeah, we did have an article that emphasized that sometimes the BMI is not the end all, and that sometimes uh, your gait and your hand strength may be better indicators of your ability to fight off infection and maintain a strong immune system. And then they emphasize the elimination of alcohol, which triggers inflammation and is something that you see many articles that talk about. Some say a little alcohol is okay, and some say no amount of alcohol is good. But all of this, I think, is very important because uh, as we age, our immune system weakens, and therefore, all of these factors that we talked about are the anti-inflammatory components that we need to keep in mind as we age to bolster our immune system. So, any questions or comments relative to the anti-inflammatory components and the anti-aging effect of having a healthy lifestyle?
Um, Arthritis is part of the inflammatory part that you're talking about.
Yes, yes, of course, that's one of the
Manual.
commonest manifestations that we deal with as we age.
Okay. Yeah, that's what my husband is suffering from. His arthritis is
Yeah. Yeah, I think there are few people who age who don't have some component of arthritis. Any other comments? Um, Now let's go to the next article. And this is something we have recognized the GLP-1 drugs. When we talk about anti-obesity medications, that's the one that they talk about more than any other. And there's an article in the Post today that talks about the fact that the government is trying to decrease the cost of these anti-obesity medications, which are very effective not only for obesity, but for diabetes and other conditions as well. And so as we move into 2026, there's going to be a real explosion of the use of these GLP-1 drugs. We are now aware that is not only good for obesity, it's good for diabetes, it's good for liver problems, it's good for kidney problems, it's good for addiction, it's good for perhaps it may be good for Alzheimer's. So there's a huge number of maladies that the GLP-1 drugs may be good for. And so it becomes important to recognize this and also to recognize that the cost of them are going down as well as recognizing that we now, the drug which started off being all intramuscular now is administered orally as well. And so all of these things will help the explosion and the surging of the use of the GLP-1 drugs in 2026. And that's kind of what this article is preparing us for. Not too many people currently are on GLP-1 drugs, but probably before the end of 2026, that will no longer be the case. Any comments or questions about the GLP-1 drugs?
Yes, good morning, everybody. This is Sylvia. Dr. Callender, I think I heard somebody says the body produces this GLP-1. I guess what?
Yes,
I
the
don't know.
intestine.
If, and if it does, how does one increase it in their body without taking the medication?
Oh, the one doesn't.
Oh,
Right. We don't. In other words, they do have this. This is a hormone that exists in the body, but this process heightens the impact of the GLP-1 drugs that are normally produced by the GI tract in the small intestine.
okay. Thank you.
Any other comments or questions? Because this is a drug that is going to be extremely popular, and hopefully, as the government reduces the cost, and as we find more applications of the use of this drug orally rather than intramuscularly, this will reduce the cost and as well as increase the utilization of these drugs. Okay, there are no other comments or questions. We'll go to the next article. The impact of GLP-1 drugs is one of the things that we don't talk too much about is what it does to the primary care physician who's actually ordering the medication in terms of understanding the side effects. And we do not yet know all of the side effects of the GLP-1 drugs. And we also do not know the impact of the administrative burdens that the primary care doctor has as he administers these drugs. And this article is indicating that we really have not looked carefully at the administrative burden on primary care physicians as they order these new drugs with their different ways of being administered, whether it's intramuscularly, subcutaneously, or by mouth, and also uh, the patient's uh, ability to pay for the drug. So all of these uh, are aspects of items that we have to consider as the GLP mania, so to speak, becomes more and more evident. Any any questions about that? I don't know how your doctor is dealing with this because it's a new issue for many doctors. We know that for obesity, it's a good drug. For diabetes, it's a good drug, and on it goes for any organ that you want to talk about. But how to use it and when to use it uh, becomes an issue.
Dr.
Any,
Callender, are the GLP drugs manufactured by extracted from the human body?
uh, the hormone, it's a hormone, and yes, it can be gotten from the body, but it's manufactured separately. Yeah, and that's why the cost initially had been prohibitive. But I think negotiations between the government and the drug manufacturers are ongoing to reduce that cost. Okay. Any other comments about GLP-1 drugs? Now, this is an article that is a very important article because obesity and depression uh, coexist. And how do you manage both of them at the same time? And one of the problems is that we don't have a comprehensive plan to deal with both because the psychological treatment that is necessary for both uh, require a strategic plan to deal with both components. And in the past, we've dealt with one or the other without a real strategic plan to deal with both. Although some would argue that in order to deal with obesity, to get a bypass, in order to do so, you first have to have the psychological component addressed. And that's normally a part of the process is to discuss why you are obese and whether it's because you eat too much, and more often than not, that's the case. And what are the stimulants? Why is it that you eat so much, and why is it that you are eating all the time? And an important component of that is psychological. And so uh, the two have to be treated as one disease entity because depression and obesity seem to go hand in hand. And just as when we talked about dealing with cardiology, heart problems, we mentioned the importance of the psychological aspect. Similarly, here with obesity, the depression aspect of it is an important component to treat along with the anti-obesity medications. So having a real strategic plan to address both components uh, becomes critical. And as such, we have tended not to recognize that you have to treat both at the same time, and you need a really holistic treatment plan in order to accomplish this. Now, one of the things that a lot of people don't recognize, and that is that obesity is actually a disease. And an inflammatory disease as well. And so the anti-inflammatory aspects of the treatment are as important as the psychological aspects of the treatment. So the question, do you treat the depression first, or I think you treat both together. I think that's, I think treating one without the other is not ideal. And recognizing that is something that this article emphasizes. Any comments or questions about this article, which recognizes and emphasizes the importance of obesity and depression coexisting and requiring a special strategy to overcome it?
I see my sister's on the line. I wish she would maybe come on and say something about this, simply because she has been overweight for much of her life. I never thought of her as being depressed or anything like that. But I do have a friend who has gone from a regular size to obesity because she just really just overeats. She loves to cook and she just sits around and eats. And I feel like she has the depression component. But really, I don't think my sister had that depression part. So I think she can address that better than I can.
Darryl, then Carol.
Yeah. I guess my question is, one part of the article said that physicians are afraid to ask their patients about obesity. Um, but if they treat them both together, the depression and obesity, that would be a lot more referrals to a psychiatrist, wouldn't it?
Yeah, would be, and there should be. And I think that's one of the missing pieces that isn't there. And I think it needs to be there. Although, if you get worked up for uh, obesity, if you're diagnosed with obesity and you go to a bariatric practice, they will often have a psychologist who's part of their team that will address the psychological aspects of it simultaneously. But so in many ways, if you go to a bariatric team, the psychologist is part of that team, and so you might not see a referral going directly, but that's an automatic part of most of the bariatric surgical practices is to have a psychologist who addresses the psychological aspects and the depression aspects of obesity, because they recognize that overeating may be just one of the triggers for obesity. Carol?
Okay, I wanted to know, their health insurance, what part do they cover for all of this?
I think they cover the whole process. If you go, if you have if you're obese and you go to a practice that deals with bariatrics, uh, they cover the whole shebang, uh, all components of the treatment. Of course, you have to get approval first, but that's part of the process. Uh, and most often, the insurance will pay for the psychological component as well.
So the best thing, if you have a friend, gently ask them, why don't they go to a geriatric or obese doctor?
Yeah, bariatric. Yeah,
Geriatrics.
yeah. The bariatric service is a special service that addresses uh, all of the components that go along with overeating, and one of the most important aspects is why you overeat, as you mentioned.
Mhm.
And For this reason, a good bariatric team will have a psychologist as part of that team.
Okay, if you're in Kaiser or some program like that, will they automatically do this for you? Or
Yes, if you participate in a bariatric practice, that is an important component of the entire exercise because one of the first things they do is try to look at the psychological component of why you're overeating, since most of the people who are obese are overeating. And so the psychological component is an important component that must be addressed. And one of the first things they do is try the psychological aspect and see if that will work. And if that doesn't work, then they may proceed to do the surgery. Carl?
Yes, Betty wanted me to say something about overweight and depression. Probably because I have been overweight most of my life, but I think probably one of the reasons that I was not very depressed, I might have been slightly depressed, is because I was always working. Because most of my adult life, I had worked two jobs, and you just really didn't have time to be depressed when you're trying to work two jobs and raise three children. So that might have had something to do with it. But I do know most of my adult life, I had worked two jobs, and that might have contributed to the fact that didn't have, depression or anything like that.
Thank you for sharing. Any other comments you want to make about uh, addressing this uh, disease entity that 50% of the American population is consumed with? Now, this is an article that talks about how grief can trigger emotional eating for patients with obesity because there often are triggers, particularly with patients who suddenly decide that they just can't stop eating. And grief can be one of the important triggers. And this is how some people deal with grief by overeating. And so that is why the uh, referral to the psychiatrist, if they don't already have a psychologist, is very important. And dealing with the psychological problems, uh, one of the things that Dr. Robinson used to emphasize when he talked about the triggers is the importance of actually interacting with the patient, not so much the drugs, but the actual personal one-on-one interaction with the patient as being one of the best ways to address these triggers, grief, of course, being one of the major ones. One of the questions that remains is, should the primary care physician be treating the depression or the psychological aspects of it? And I think that the best treatment is to have the person who is the mental health professional to deal with it. So the referral from the primary care physician to the mental health professional is very important. And the balance between drugs and the one-on-one interaction is something that is important. Now, we also have recognized that for older patients, patients over 65, that there appears to be anticonvulsant therapy, which can be of benefit when the depression is resistant to the conventional medications. and the one-on-one interaction. So there are many different ways and new drugs that are being used to address the depression-resistant treatment. Darryl?
Yeah, I think it's interesting. They suggest that patients can keep a food and emotion journal to become more aware of eating triggers.
Yes, very interesting. Yeah. Um, I don't know of the impact of that, but that does sound like an interesting way for the patient to become aware of the impact of what they're doing by keeping a journal. Betty, you had a comment?
Yes, the part about grief and maybe help starting the obesity, the overeating or whatever. That same friend I mentioned earlier, she was caring for both her parents. They, so it wasn't really grief, but she was caring for her aging parents. And not one, but two at the same time.
Wow. Wow.
And she said she would call me lots of times and just to have someone to talk to, But that I feel too was some of the triggers of why she kind of overate
Yeah,
and had the depression.
so
Yeah.
you were part of her therapy, huh?
Yeah, I tried. I tried. I'll tell you a story about she said when she was taking her parents one time to the doctor, her mom in a wheelchair, her daddy on a cane and walking beside them. She said a woman coming toward her stopped her and she had her mom too taking her, and she said the lady stopped and said, gee, I'm not going to complain anymore because you have two. And that has stuck with me. But she did it for years before her parents died. Yeah.
Mm, mm. Yeah. Well, it's amazing how some children can be so faithful to their parents, and some are just the opposite. So, yeah.
I call it a continuation of the aging process. Um, I've been through it, but it's 8 siblings. But of course, it wasn't all 8 trying to help out with mom and dad. And my sister and I referred it to, they raised us. Now we're raising them. And
Hmm.
it's like having an extra child around, and you
Hmm.
just do it. Yeah.
Hmm.
Mhm.
You do it if your inner self requires it of you,
Yeah.
because not true in all
Mhm.
children. So,
Mhm.
and
That
it's interesting to
particular
see how which of the siblings are sensitive and which are not.
Yeah.
the particular girl I was talking about was the only girl. She had two
Oh,
brothers, but
Mm.
you Janice, I think you know the women step up more
Oh,
than
yeah.
the men.
Absolutely.
So
Yeah.
well, the old adage is uh, son is yours till you find a wife.
Mhm.
Girl is
yeah,
yours for the rest of your life.
rest of
Yeah.
your life.
And just listening to Betty made me think of an incident with my mom and dad. And my dad used to love to walk. And as he aged, maybe that was a form of dementia. He would walk. And sometimes we didn't know where he was. And my mother would call me, Daddy's outside walking. And I'm on the phone at work. Daddy, Daddy. I said, Mom, put the phone to you can't go out today. Daddy, stay in the house. It's what we had to do. And yes, I've had to leave work and go home. Daddy, stay here. Do this. Okay.
Yeah.
Yeah. That's what you do.
Yes, that's
Yeah.
what we do.
Why is it? But you wonder why is it that the boys aren't as sensitive to that as the girls are. But it's an interesting observation that seems to work.
Mhm.
Yeah,
And you have exceptions to every rule.
Yeah.
So, yeah.
yeah. This same young lady would say that one of her brothers would say, I'll give you 1 day a week or something like that.
Can you
But
imagine?
and 1 day a week wasn't a full day.
Right.
It was just, a few hours. I'll come over and do a couple of things. But
Mm.
Yeah,
yeah.
that's an interesting aspect of the male-female relationship, and
Mhm.
makes you, I just noticed that they have a female governor for, I guess, New York, I think, was first female.
Virginia.
Yeah, and it makes you wonder if we would be better off if we had more female leaders across the globe. Food for thought, anyway.
I know in my family, I found that my brother was not as sensitive to my mother's needs as I was. And um, he would leave her alone sometimes when he should not have, but the sensitivity was not as great.
Yeah, not comparable, really.
Yes.
You're kind.
Spe- Speaking
Betty?
for, yes, speaking for myself, um, my brother, I had two, but the one next to me in age, the youngest one, was a medic in the Navy. And so when mom, needed things, I would call him and ask him to do this, that, or the other. But his response to me was, I hate to see mama like that. That was why he didn't come,
Oh,
or
that's
he
that's
didn't
no,
participate.
that's that's a weak excuse, isn't
Very weak.
it?
Yeah.
Yeah. Mm. His hating the Sears isn't going to make any difference.
Uh,
Okay.
I think it's because women, we start off young. We are training ourselves to be caretakers by when we start playing with baby dolls and learning how to dress and undress them. Then when you have children, you're taking care of that children that's helpless. Um, and you're practicing all along. So you're getting that experience, and that not all women are like that. Like you said, there's always exception to the rule. But one thing when you're talking about is talking, whether when you go to a psychiatrist or a counseling, what you're basically doing is talking, and they're helping you to sort through your feelings. And when we're going through our problems, because I know this is attributed to me, when I'm going through something, you have a mate like John, I'll talk his head off, especially when something is bothering me, or I got to find somebody to talk to. And I'm thinking people have more problems when they don't have someone to talk to. You live much better when you have someone to converse with or to share your problems or feelings or what's going on with you. It may or may not be true, but I think you live a longer life when you got that companionship or someone just to talk to, psychiatrists and counseling. Because I remember once when I had to do a half blank job of being a counselor, but the only thing you did was sit up there and listen and then offer a little bit of help, but you can't offer too much. And I'm thinking of psychiatry. All they're doing is listening and help you sort through your feelings. And someone was saying, take a note. You can help yourself. When I start eating, what's really bothering me? Then you got to talk it out. Okay, I'm eating because either I'm hungry or I'm irritable or something, or somebody messed me up, so I got to eat, or your anger. So I think the comfort of the whole thing is to talk somebody or meditation and prayer, and just think about it as you take your walks. I don't know how everybody else handled their problems, especially when you're living by yourself. What do you
Mm.
Mm-hmm.
do?
Thank you for sharing. You brought up some very important concepts. Yeah. Okay. Any other comments? If not, the next article is an article that talks about the fact that if you got pre-diabetes, that you can uh, have a remission. For example, when we talk about prediabetes, you're talking about a situation where you've got a hemoglobin A1C that's greater than 5.5. And so you don't have the frank diabetes yet, but you're on the way. And most often we talk about handling that by losing weight. But this article is saying that you can reduce your hemoglobin A1C even without losing weight and still uh, keep from having developing diabetes. And this then is a plea to adopt a healthy lifestyle, even if you don't lose weight, and that you can, uh, by lowering your hemoglobin A1C and blood sugar, you can avoid the consequences of hyperglycemia and the all the ways in which it negatively influences your blood vessels and your organs. And so that this is one of the aspects of prediabetes that we tend not to talk about. We talk about remission by losing weight, but this article is suggesting that that's not the only way. Darryl?
Okay, yeah, the article's talking about redistribution of fat, moving it from visceral fat to subcutaneous fat. And I think I understand visceral fat. That's the isn't that the beer belly look?
That's the around the organs. Yeah, yeah.
Okay.
In other words,
So
you got fat all over your organs, and
right.
and,
So
and as you said, belly fat, as contrasted with butt fat.
yeah. So they say subcutaneous fat is neural fat storage just below the skin.
Right.
Well, what does that look like?
Well, it just pot belly is probably the best description of it, uh, because all of the fat is right under the skin, between the skin and the muscle, uh, and the pot belly is the greatest example of that. Uh, and also the fat being around the viscera, the organs, uh, which doesn't help either. So, and for that reason, the concern about uh, eliminating uh, the subcutaneous fat. And they talk about different exercises that you can have in order to do so. But that's what they mean by the visceral fat. In other words, viscera meaning the organs and fat, subcutaneous tissue around the between the skin and the muscles, and also around the organs themselves, which is undesirable. Betty?
Yes, so if you have the pot belly, does that automatically mean that you have fat around your organs as well?
Suggests it, yeah. Yeah, it suggests that you have a lot there and probably similarly around the organs. Yeah, that's the suggestion. Now, the glucose measuring tools now are very common because there was a time when most people weren't measuring their blood sugars by instruments. Nowadays, uh, we have ways of putting the measurements in under the skin, and they can instantly give you a measure of your blood sugar. And this then Uh, I think, when you talk about waist circumference, the waist to hip uh, ratio, that's a way of looking at the amount of body fat that you have in comparison to uh, uh, to the amount of real lack of fat, and because you've got skin, you've got subcutaneous tissue, then you have muscle, and when you have a lot of fat between the skin and the muscle, then that is not desirable, and that's uh, what is the negative aspect of it. Uh, Darryl and Joyce.
Okay, so if I'm understanding this, let me know if I am. If you've got a visceral fat problem, uh, the pot belly, and your blood, you're in a pre-diabetic disposition, then it's saying that if you change your diet to eliminate the saturated fats, if you do aerobics and resistance training like weightlifting, you may not lose weight, but by doing that, you'll redistribute the weight to subcutaneous, and so you can get out of pre-diabetic condition without losing weight, because by doing those lifestyle changes, you've redistributed your fat. Um, is
That
that
that's
is-
that's exactly what the article is saying. Yeah.
okay?
Joyce. Joyce.
I was concerned about the fat that's around your organs. Does it have an impact on the performance of your organs?
There is an evidence that it does. Uh, it's just that uh, the fat is still undesirable, but I think having it redistributed uh, uh, allows the uh, hemoglobin A1C to get closer to normal, which is what you're looking for when you have pre-diabetes, is to get to the point where you don't have so much sugar in the bloodstream,
Okay.
which is then toxic to the blood vessels.
Okay. Thank you. That's good.
Any other comments or questions? If not, let's. Um, Now, of course, the one important part of this is you knowing what your hemoglobin A1C is. Um, Prior to the last decade, we talked more about the blood sugar and saying that the blood sugar should be 100 or less. We now know that that's one measure of it, but it's a time measurement, whereas the hemoglobin A1C is the best way of telling whether your uh, sugar in your bloodstream is so high that it can be toxic to the blood vessels and cause arteriosclerosis and therefore uh, decrease the circulation of blood and oxygen in your organs. And so that's why the hemoglobin A1C is thought to be the best measure, because it not only addresses what the level is today, but what it's been over the last 30 days, so to speak. Whereas the blood sugar measures only the time that you get the blood drawn. So that's why the hemoglobin A1C is the better measure of uh, the exposure of your blood vessels to the uh, amount of glucose in your blood system, in your circulation. Okay. This is an article that talks about the way in which exercise enhances weight loss maintenance because uh, again it's also again a redistribution of the fat with loss of the fat, and the exercise uh, creates the muscle tone. Uh, and one of the things that we have to guard against with the GLPs is the fact that we lose muscle as well as fat. And of course, the goal is to lose the fat and retain the muscle. And in order to do this, I think exercise then becomes the missing link that allows you to lose the fat but retain the muscle. And that's why the resistance exercises that Darryl spoke about become so important. Any other comments or questions about the the observation that with GLP-1 drugs, you may lose the fat and the muscle. And so you have to direct your attention towards maintaining the balance of the muscle. Lose the fat, but don't lose the muscle. So this is an important aspect of as we use more GLP-1 drugs it becomes even more important to have resistant exercise, weight lifting and other resistance exercises.
So, Dr. Callender, you're saying that the GPL-1 drugs, you will lose the fat and the muscle if
Yes,
you want. Okay.
that's right. If you don't work at it,
Mhm.
right, you lose both. And that's why exercise is important, plays an important role if you're on GLP-1 drugs. Because you want to lose the fat, but you don't want to lose the muscle. Now, this is an interesting article that coming up now. Does bedtime dosing offer any real advantage over morning dose for blood pressure control? And this exhaustive article identifies that there's a slight advantage to taking medication at night. Uh, but there is also control that occurs because you take medication in the daytime as well. But there does seem to be a small advantage to taking your blood pressure medication nocturnally. But it doesn't seem as though it's an enormous advantage, but it is an advantage nonetheless. And but I think the article kind of suggests that the advantages is not so enormous as to make it a mandate that you take your blood pressure at night rather than in the morning. And I don't know how many of you take blood pressure medicines once a day or twice a day, but does appear to be a slight advantage to taking uh, blood pressure medicine at night. Any comments or observations to the contrary? As they're just more and more studies that are looking at the uh, nocturnal versus the daily administration of drugs, and so these are the current studies. But it's interesting as you watch from year to year uh, the controversies about what is the desirable blood pressure and whether there is a distinct advantage to taking your blood pressure medicine at night. One thing is clear is that we need to do better at controlling our blood pressures, and this means that we need to be able to take our blood pressures at home uh, and keep a record of them and share them with your primary care doctor so that they can ensure that you have your blood pressure controlled, which would decrease the number of deaths from cardiac deaths in the United States and the world. Darryl?
Yeah, I think if you're going to switch from taking your blood pressure medicine from the morning to bedtime, it's worth a conversation with your doctor to make sure it's not conflicting with other drugs. Even supplements, things like magnesium, if you're taking that as a supplement, that can also lower blood pressure. If you're taking magnesium and your blood pressure medicines at bedtime, that could lead to too low of a drop. And so, that's a situation where you may want to switch magnesium to morning if you're going to take your blood pressure medicine at night.
Good advice. Okay. Thank you, Darryl. Any other comments? Okay, let's go to the next article. This is an article that talks about stroke treatment success. A little complex because it really addresses the role of endovascular treatments, which are important for causes of stroke that are ischemic, which means a lack of circulation, in contradistinction to the stroke that is caused by hemorrhage. The treatment of the ischemic stroke is very different from the treatment for the hemorrhagic stroke. And the best results are associated with the treatment of the stroke in which you have a obstruction of circulation. And their endovascular removal of the clots may well be very beneficial. But the complications that occur as a consequence of the stroke, with the thrombolysis being one of the treatments that they employ as soon as you get into the hospital, and that's why whenever you have any sign of stroke, you need to go to the hospital right away so they can decide whether you can treat with dissolving the clot or removing the clot for the ischemic stroke. Whereas with the hemorrhagic stroke, then the treatment is to reduce the blood pressure and prevent the hemorrhage from continuing. And depending on which of the strokes you have, the ischemic or the hemorrhagic, the treatment would differ. With the urgent removal of the clot by medication or by surgery, the sooner you get the treatment, the better off you are. And I think that probably is the component that is more important than any other. That is implementation of treatment. The closer to the time of the stroke, the better off the results are. Darryl?
I'm sorry, didn't mean to raise my hand.
Oh, okay. All right. Any other comments? And the real emphasis here is whenever you have any problem with the face or the extremity, or you can't see, go to the emergency room immediately. Have somebody take you to the emergency room immediately so they can implement treatment as soon as possible. And the sooner they get to give you the lysis of the clot or the removal of the clot or lower your blood pressure so the hemorrhage can stop, the better off you will be. Now, this is an article that is very impressive in terms of the new CPR guidelines to save young children or infants who have arrests. And it talks about the techniques of using the two thumbs as well as using breathing along with the compression, and also talks about the importance of hitting you in the back um, if you get food stuck, because we talked about the Heimlich maneuver in which we do the abdominal thrust, but they have not eliminated the importance of hitting you in the back as being a way of getting the food to be dislodged as well. But the CPR in the young infants and children becomes very important as well uh, as uh, uh, as the 2 or 3 breaths per minute for the young children as well. Uh, any comments about this? I don't know if any of you have had the opportunity to use CPR on younger ones, but uh, uh, the complication of breaking ribs and those kind of things are the reason that they talk about using two fingers rather than the whole hand. But this is an important CPR is important for people to have to have training for. It's just that it's different with the smaller children because your hand is likely to break their ribs, so it's important to use the 2 thumbs rather than the whole hand itself for the children. That's part of the new guidelines as well as using epinephrine, which is an old uh, therapeutic modality that we've always used to help us as we deal with somebody whose heart stopped beating. Well, one of the issues that comes up is in the churches and in the public groups, do you have people who, with athletics, they always have a health team that is ready to resuscitate or cause defibrillation. And in the churches, uh, often that is not the case. I know in our church we have a defibrillator, but nobody really knows how to use it. And what good is it if nobody takes the training? And that's for the adults, but for children, it's less common. Anyway, so CPR is something that I think it should be part of every church should have CPR training and also learn how to use a defibrillator. First have a defibrillator, and then second, know how to use it. Carol?
I noticed in the Baptist denomination, some of them, they still always have those nurses, the nurses aid, and now they're requiring them to take CPR and in the congregation. But in other denominations, such as Presbyterians and Episcopalians, I don't know about the Methodists, but they don't have that group nurses aid. Well, one thing they still do is wear the white dresses and those white hats to signify that they're nurses' aid of the 30s and 40s and 50s. But I do know they're in the Black Baptist denomination, and they do take the training now.
Yeah, and I just wish it were true in all the denominations, but I'm afraid it isn't.
But the other denominations, they don't last as long. So 1 hour is nothing compared to 2 and 3 hours where somebody might actually go into something.
That's true because the Baptists are a little longer. The Presbyterians are a little shorter, and the Methodists are somewhere in between. So, but I think all of the churches should have a defibrillator and should have somebody trained in CPR. But that's not the case. Betty?
Yes, I have taken the training at Baptist at Liberty, and they announced recently that it's time to renew because you have to renew it ever so often, every 2 years, I think. And I don't remember them teaching us how to do the defibrillator, but they did teach us about resuscitating and how to mouth to mouth and the different things like that. So it was
Yeah.
very interesting. Yeah.
Well, do they have a defibrillator?
I think they have one in the nurses unit. I believe they do.
But if nobody knows how to use it, what
And
good is it?
yeah, but like I said, maybe because I wasn't really, I'm not a nurse as far as being on the nurses unit there at the church, but I just wanted to take the training. So they said anyone could take the training, so I did. But I feel like the nurses there who are actually sitting back there with the white outfits on, like Carol said, I think they probably have had that training. And some of them are actual nurses, at least they used to be actual nurses that, you know, had the situation, so they know how.
Your presumption is they know how.
Yeah, my presumption. Well, I
Because
know the
the
real
reason I
nurses.
say it's your presumption is because you need to have defibrillator training periodically, just like you need CPR.
Yeah, yeah. So yeah, it's my presumption that the nurses who are actually on the unit, you know, that say I'm a nurse sitting in the back of the church to help if something happens. I think they have, don't know for sure, but I think they have. But in the past, we have had real nurses from hospitals that are on that board. So I know they know how.
But do you have a defibrillator?
I'm not positive, but I think so. Not positive.
Yeah. Okay. Well, that's the problem that I have is that we have a defibrillator, but nobody has been trained to use it, and it's like not having a defibrillator. And uh, well, it's it's not required, but it's it's interesting. When I was younger, I used to have to go and resuscitate people, but now that there are fewer people in the church, fewer people to resuscitate. So, so I don't know. It's food for thought, though. But I just think that church should have the ability to do CPR and as well as defibrillator, and somebody should be trained on how to use the defibrillator. So that's just
Dr. Callender, with our society, is there any place else that people gather and they actually got someone? Okay, you look at the theaters and the movies and the plays and etc. Is there anybody at the facility that can actually do this? It's a requirement, or is the church the only place where people meet? That if you're in the right denomination, they might have somebody on board.
well, theaters and public places generally are required to have defibrillators. Now, the impression is that there's a lot of information on the defibrillator, so it can take you through it by itself. But if you have a defibrillator and somebody there should have the knowledge of how to use it. But all athletic events and theaters and those places should have defibrillators because defibrillators save lives. Okay, moving on to the next article. This is an article that you have all this talk about autism, and one of the things about autism is that it's kind of hard to describe what autism is because there's a complexity of disease entities in which people actually life resolves totally around them, and the different behavioral modifications and the way in which people manifest this disease of autism is interesting. But one of the things that is clear is that the environmental component of pollution may be more contributory to autism than many of the other factors that they try to imply. Still haven't seen much evidence that Tylenol is related to autism, or anything else, or vaccines or anything else. But this is, but it's becoming clearer now that the environmental pollution contributes to autism. And yes, autism is being diagnosed more often, and autism has many ramifications uh, of how children or adults are incapable of dealing with others and are more tied into themselves, and different ways in which autism can manifest itself, sometimes with high IQs and sometimes with low IQs. But anyway, I think that it's a subject that has been had a lot of discussion about it because of the president and others, and RFK as well. Uh, but we still need more data so we're better able to uh, diagnose and understand it. Um, any comments? Any of you have any experience with autistic adults or children? Yeah.
Yeah, just trying to get a handle on where this air pollution is coming from. The article suggests that it's coming from fine particulate matter, and that can be in urban environments. Some of the sources can include cars, trucks, buses, factories, construction sites, and the burning of wood. So, like wood burning fireplaces. I've got an air quality monitor at home, and one of the first items on the screen is the fine particulate matter, and it shows up as PM 2.5 particulate matter. And so I've got good air quality in the house, and I noticed that um, when it when it comes up just a little bit, it's normally not coming up from the gas stove. It's normally coming up from just spraying things in the air, whether it's cooking spray or anything out of an aerosol can seems to increase the amount of fine particulate matter in the air.
Thank you for sharing. That's interesting. One of the things that I wonder about is whether, one of the things that they've observed is that we have more cancers in young people than we ever had before. And some of it is related perhaps to environmental pollution, but also to the PFAs and the other substances the plastics and other substances that we're exposed to more now than ever before. And then, of course, something that you mentioned often is the pesticides as well. So that all of these are pollutants of different varieties, but uh, probably we have more pollution than ever before. And this may be a bit more contributory to autism than anything else. Any other comments about changes? The next article is, was your hand still up, Darryl, or not? The next article is about why do non-smokers get lung cancer? And what is problematic is that the number of non-smokers who are getting lung cancer is increasing. And they're trying to look and figure out why. And is it secondary smoking, or is it the genetic component? And this article had noticed that the type of cancers that occur and the treatment for the lung cancer. Lung cancer is still the disease that kills more, is the cancer that kills more people than anything else. And so trying to make an earlier diagnosis of lung cancer when it's treatable becomes very important. And we have the pollution We, Darryl talked about the pollution and the radon and the other things. Uh, we also have an element that we don't discuss too much about, but that is when you use radiation as treatment for cancer, that this can itself increase the likelihood of lung cancer. And so also the importance of screening uh, becomes important to make an earlier diagnosis because we do have some treatments for lung cancer, surgery as well as chemotherapy. Uh, but it is a fact that the number of lung cancers in non-smokers is still increasing. And so this is food for thought. Darryl, you have a comment?
Yeah, I'm very interested in this subject because my mother had lung cancer and she was a non smoker.
Mm.
And one thing that was consistent throughout her whole life was she always had gas cooking stoves and ovens, never had electric. And I noticed with my air quality monitor, whenever I'm not running the hood fan with my gas stove, the numbers go up a lot. And it's said that the volatile organic compounds coming off of gas stoves is is a leading carcinogen.
Mm. Interesting. Very interesting. Mm. Actually, my father-in-law, I guess, he died of lung cancer, and he was a non-smoker as well. But he was around a lot of people who smoked all the time, and that was a difference, and that may be how he was exposed to it. Any other comments about cancer in non-smokers? Because we know that it is common in smokers. Betty?
Yes, long time ago, excuse me. A long time ago, you used to be able to smoke inside and, wherever you were. But then they started making everybody go outside to smoke. And just putting all those pollution in the air outside could have something to do with it because, with everybody going outside, you when you were inside, you were just affecting your family. But going outside, you're affecting everybody.
Yep, that's true. Any other comments you want to share? Yeah, very true. Very true. Um, this is an article that talks about laughing gas as another option for resistant depression in older adults. We talked about the anticonvulsant therapy as a choice for resistant depression in older adults. But laughing gas is the gas that we use for dental, and it's a gas that can be used as well for the treatment of resistant depression, which is interesting. And what they call it laughing gas because it put you to sleep, but it also made you laugh. But apparently, this is also a treatment for resistant depression in older people. So they're not familiar with it being used before as a therapy for resistant depression, but this is a study that demonstrates that it is a therapeutic advances. 85% of patients. That's a significant number. And it's interesting to observe nitrous oxygen being effective in that way. Any comments about this? It's interesting how we talk about treatment that is good for older patients who have resistant depression. Therapy is being efficient for them, which is not efficient for patients who are under 65. And this is interesting because we have recently talked about the use of anticonvulsant therapy, electroconvulsant therapy, being effective in resistant depression in adults over 65 as well. But this is much more desirable than electroconvulsive therapy. Any comments? If not, we'll go to one more article I think we have. We talked last time about gait, and one of the things that just as we talk about the ability of somebody to shake one's hand and be strong at that, if you look at the way people walk, you can tell much about them. The gait, just like the handshake, can be used to make diagnoses about many people in terms of the way they walk, their style. You know, what used to be hippity hop is different as you age, as you get past 60, 70, and 80, the gait changes. And they now talk about an instrument that measures the gait. And by the gait, you can make a determination of what's going on in terms of making the diagnosis of Parkinson's disease as well. I know last week a question was asked, well, do doctors measure the gait? And maybe we don't, but we should, because just watching somebody walk can tell you a lot about their neurological system. The neurologist knows more about gait and balance than probably any of the other physicians. That's the neurologist. Yeah. And so, yes, gait is a measure of one's neurological state. And Parkinson's is one of the diseases where gait is an important part of that. Darryl?
Yeah, I just wondered if there's different characteristics of gait. I know you could have a steady gait, a shaky gait, whatever, but one obvious difference is fast walking or slow walking. Is that an indication of gait?
No, I don't think it's the rapidity of the walking. It's the way in which you walk. Uh, although there are ways to measure the gait, and they talk about this virtual gait test that they have, and I think what it is measuring is the rate you walk and also the style that you walk, because the so-called limping and the different uh, ways in which you walk are affected by your hip and your presence or absence of aseptic necrosis and those kinds of things, which would affect your ability to walk. Uh, there is a school of thought that says you are frail if you can't walk a certain distance in a certain period of time. So there is in answer to your question, there is a time table for the gait as well, which is a balance between whether you walk fast or slow. But because some people, as they age, their ability to walk slow becomes very exaggerated. And that's why this virtual look at the way in which you walk, and the rapidity with which you walk becomes important. Betty?
Yes. What about a person who kind of shuffles along rather than actual taking steps?
That's the Parkinsonian gait. Shuffling is the Parkinsonian gait.
Okay. What's that? That's like you.
Yeah, Parkinson's disease is noted by the shuffling gait. Yeah. Darryl?
Something off the internet says fast walkers associated with are associated with the younger biological age. Studies show that fast walkers may have a biological age that is up to 16 years younger than their chronological age, based on various health markers like telomere length. And slow walkers, that's a sign of accelerated aging. Slow walkers often show signs of accelerated aging, appearing older biologically than their chronological age. And the tip is to pick up the pace.
Thanks for sharing. Good. Okay. All right. So it's another measure as a way of, just like hand grip is a measure, so can gait be a measure of the aging process. Okay, I think this will be the last article for us, and so it's 10:30. So thank you, Darryl and Carol, for doing such a great job in Buchanan's absence. And I mean, I must tell you that it's hard to say he was missed. You guys did such a good job. I mean, it's so spontaneous with Darryl and Carol that, wow.
Well, this is John's computer, and he taught me everything I know. So, and John is online, and he's recovering nicely. And I just want to let everybody know today, way back well, I won't tell you the year, November the 6th, in Linwood, California, in Los Angeles County, I was born today, and it happened to be on a Thursday. So this is a year. Yay.
What year?